Hello, everyone. This is Shad Reis from CVI 2025. I'm privileged to be with Dr. Mahesh Anantha to talk about how to perform high-risk intervention in patients with no surgical backup and center with surgical backup. So, Mahesh, thanks for being with us.
Thanks, Shadi. It's always fun to be here, and it's a great meeting as usual. Today, I wanted to take some time and just talk about our program. That's kind of a little unique practice compared to the rest. Every time you go to a place, they say, "Oh, you don't have a surgical backup. You can't do a whole lot of things." I'm a faculty from UMS, but the hospital I work from is a community hospital with a lot of stuff that we got in the last 4 years. We just have a way of doing it. So I just wanted to just say it's doable in a small program like this. But we have access to every atherectomy device. We do all the complex coronary stuff, including collateral, CTOs, epicardial, septal. And we also have complex high-risk cases. With Impella, we have access to RV Impella, LV Impella, as well as we recently got in the last 4 months, or actually a few months, we've got access to VA ECMO and stuff. So how we operate is, obviously when we start the first thing, we have to be careful. The new program, you don't want to end up with complications starting an Impella program or starting any cardiogenic shock program. We are one of the 7 hospitals in Arkansas with the cardiogenic shock initiative. We participate in that. We started the program, as I always say to all the fellows, just to, in the first 6 months, or even as a new intervention faculty to a year, it's important to just make sure you don't have any mortality on your table. Just making sure you make the administration believe in what you're doing and show them the good outcomes, and you stay away from complication and get 100 cases under your belt. And that's how we did when we started the program, trying to show them this is doable. And every time we talk about a swan, people start freaking out. The culture in that place has been the same for 40 years. It's difficult to change when we start establishing a program like that. But it took a little while, but we were able to move it. And we started doing things slowly, and we started like, okay, swan is manageable on the ICU. And then we started doing, they were doing balloon pumps before, but nothing else. And we put the first Impella case, and I stayed with them all night long, making sure everything is okay. And always nice to plan when you start a complex case to do an elective stuff rather than a cardiogenic shock patient first. So we did an elective PCI first. So not the most complex left main. We started with some decent bifurcation with a kilowatt technique, and we did that first. And then we ended up getting access. We said, okay, we're managing this, but we don't have access to protect the RV site, and what do we do about it? And then we just said, okay, let's get an RV Impella in place. And we have some patients that we did by RV Impella had good outcomes. And then they were questioning about, are you able to do like all this complex CTOs and stuff without having surgical backup? Yes and no. I feel like it's doable as long as you're safe and you know where to stop and not running into complications. We have all the atherectomy devices, CSA, Shockwave, and Rhoda. So anytime it's needed, we offer them. But I think it's doable as long as you feel you're safe and you've gotten a good number of cases under your belt, and convince the administration and show them good outcomes with elective cases first, and then move on to just doing some signing up for a complex program.
So it's very slow. You started very slow, gradual.
Exactly,
And then
yeah.
showing the outcome is safe.
Right,
Because that's
right.
reassurance for them before.
Exactly, yeah.
Because the whole system can be kind of, not threatened, but the kind of going to be under scrutiny if something goes happen.
Exactly. I mean, the hospital administration, at the end of the day, we all have to understand it's healthcare, but it's also a healthcare business. So for them, they're running something and you're running something. So it's important for, at the end of the day, patient care really matters, and they want to make sure that we take care of them. But also they also want to make through the financial aspect of them is feasible for them, and you're not causing complications that they're getting in legal trouble. So from every perspective, we just have to think, not just as a physician asking for, I want to do this, I want to do that, but not taking care of them. As a system, we work as a team and try to take care of patients. So we establish this program slow, but also having a backup like we have right now is with Baptist, we have a backup. So every time we end up placing a VA ECMO for a cardiac arrest patient, we have a protocol. But by the time I put an ECMO, I do a coronary angiogram and a pulmonary angiogram. There is a flight that's already flying from Little Rock Baptist to get them. So we don't maintain ECMOs at this point. We just place ECMO patients and then stabilize them to a point. We do coronary angiogram, PCA, whatever needs to be done, and then we put them immediately on the chopper after they get it done. So the 45 minutes for them to fly from there, or 20 minutes actually fly from there to here, the moment you activate the protocol, their system gets activated, and they always have a bed reserved for us anytime for this. So we just have the program combined going like with them. So it's similar to Detroit Cardiogenic Shock Initiative, but we should establish. We try to do the same thing, replicate the same protocol and whatever it is. And it's been going good. We've had some good outcomes the last few days. So the program has been successful. So anytime you open a small balloon, it says you have to have a surgical backup.
Yeah, absolutely.
So then SCI consensus came up recently saying things that atherectomies and stuff and CTOs can be done in place. And we're trying to put together a paper so we can say outcomes are good when we do some CTOs and complex cases in our institution. So we're proud that we've established in the last 4 years. Things are going really good.
Thank you so much, Mahesh, for your experience, and again for working in the program with no surgical backup and how to build complex race cases as well. Watch these videos and others on CVI YouTube channel. This is Shad Reis coming to you from Austin, Texas.